Well, let's go ahead and get started. Thank you so much to everyone for joining us here for today's Doctors In program to talk about advanced care planning. This is actually a topic that we've done a couple Doctors In sessions on over the years. And some of you who've been to these programs in the past may remember we did some surveying over the summer, and this was one of the topics that scored very highly as one that people wanted us to repeat. So maybe you've heard similar information before, but you might be at a different point in your advanced care planning process, or maybe you're coming for the first time, and in either case, welcome. Doctors In is a partnership between us as the Elder Initiative at the William Wade Community Center and the Jefferson Department of Family and Community Medicine. And so we do these programs each month, covering a different health topic, with Jefferson doctors coming in to share their expertise, answer your questions, and share information and resources. And we are fortunate today to be joined by Dr. Dana Hovern, who is a palliative care fellow at Jefferson. This is her first Doctors In program. Very happy to have her here with us. Before I turn it over to Dana, just to go through the quick housekeeping things. On Zoom, there are a couple ways to ask your questions. You can put questions in the chat. If you see the chat icon in the toolbar at the bottom of your screen, do know that when you put things in the chat, your name is attached to it. If you prefer to ask questions anonymously, you should use the Q&A feature, which you can also find in the toolbar at the bottom of your screen. When using the Q&A, there is an option to keep your name private. So if you have anything more personal that you don't want to be seen with the whole group, you can use the Q&A and ask your questions anonymously. I'm going to be keeping an eye on the chat and the Q&A, and we'll relay those questions to Dana throughout the program. And then we'll have some time for questions at the end as well. We are streaming live on Facebook. For anyone watching us on Facebook, you can put your questions in as comments, and I will get those to Dana as well. All that being said, thank you again, and I'm going to turn it over to Dr. Dana Hovern.
Thank you so much for that introduction. It's a pleasure to be with you today and to meet you all virtually. Thank you so much for coming. So we are going to be talking about advanced care planning. I am a current palliative care fellow at Jefferson. And this is something that I do every day, and I love talking about it and getting the chance to share it with you. Prior to my time at Jefferson, I did my internal medicine training at Lankenau Hospital and did my med school at Cooper. So I've been in the Philly area for the majority of my training. Feel free to ask questions at any time, and I hope that you guys find this helpful. All right. So we're going to start with some definitions. I'm sure that you've heard the term advanced care planning. You might have heard of things called living wills. I'm going to break it down for you so it's a little bit easier to understand exactly what these things are and how they play into the bigger picture. So advanced care planning is actually the process of sitting down and talking with yourself, with your family, with your doctors about what kind of care you would like at the end of your life or as you get sicker. And it's also the process of identifying someone who you would like to speak and make decisions for you in the event that you're unable to do so yourself. Power of attorney. So a power of attorney is someone who can legally make decisions for you in a legal sense or in any financial matters. This is separate from what the next definition is, which is medical power of attorney. Medical power of attorney is synonymous with healthcare agent and healthcare proxy. So this is a person who has legal authority to make healthcare decisions for you if you're unable to speak for yourself. And sometimes your medical power of attorney can be the same as your non-medical power of attorney, your financial one, or they can be two separate people. It's completely up to you, but you will need legal documentation of who you would like to be either one. And then an advance directive. So an advance directive is a legal document that outlines the specific types of treatments and care you would like to receive. And this is something that you would give to your medical providers. It's something that you would give to your medical power of attorney, so that, God forbid, if the worst happens, we would know exactly what kind of care you would like to receive. So, like I said, advanced care planning is the process of talking with your trusted people and any healthcare providers in your life about what you want to get out of your medical care. I tell my patients that this is really a proactive process. We always hope for the best in our life, but it's really important to prepare for the worst. And it's important to have these conversations while you're able to. So that way it makes it easier for you and your loved ones if the worst case scenario does happen. There's two parts to advanced care planning, and I mentioned both of them already. So the first is kind of identifying a healthcare power of attorney, your person who would make medical decisions for you in the event that you're not able to speak for yourselves. And then the second would be making an advance directive. So this is the document, the living will, that talks about the specific treatments you would like to receive if you were to get really sick. Now, both of these things are fluid and they can change at any time. Say, something happens to your healthcare power of attorney, they themselves get really sick and they're unable to take on that responsibilities. You can transition that position to another person in your life. Say, you change your mind and you're more interested in certain therapies than you were when you had made your advance directive. Once again, you can change that at any time. And it's really helpful to kind of go through this process with your family so that it can be less stressful for them as people are approaching end of life, or if they happen to get really, really sick. Okay. So we'll start talking about those documents. So an advance directive. So it's a legal document. It outlays the healthcare decisions that you would want for yourself in the event that you can't speak for yourself. It's also known as a living will. On the medical end, we use these things in the hospital to help guide the family with making medical decisions about the kinds of treatments that would be acceptable to you. Oftentimes, patients will come into the hospital really, really sick. And as doctors, nurses, we're not really able to ask them what they would want done with these more intensive treatments. And it can be really stressful for the families to kind of try and answer those questions for the patient. But the advance directive living will is a document that has all that information already laid out, and it can really be helpful to the people taking care of you and to your family members to have that document available when you need it. It only applies to healthcare decisions. So the living will has nothing to do with your financial or legal matters. It's really only about the kind of care you would want. And there are certain variations legally across the state. I looked into this a little bit for Pennsylvania. I do have that information in an upcoming slide. So there are two types of advance directives that we kind of talked about. The one being the living will, that's kind of where you would outline the medical therapies you would want to receive or not want to receive. And then the second is the durable power of attorney for healthcare. That's the one where you say, I want this person to make medical decisions for me in the event that I'm not able to communicate for myself. So we'll break this down a little bit further and talk about each of these different types of documentation. So the living will, like I mentioned, that's kind of the legal document that you would state your future healthcare decisions. It can be used at end of life. It can be used when you're unable to communicate with your family and your providers about the kind of care you'd like to receive. Usually it includes discussions about these following life prolonging measures, things like dialysis, ventilation, code status, organ donation. And I broke this down in further slides so we can kind of talk about them further. It can vary from state to state, as I previously mentioned. And in the state of Pennsylvania, it does not need to be signed by a lawyer, but it does need 2 witnesses, or it needs to be notarized. And if you happen to be in the hospital when you're completing this paperwork, I know at Jefferson, we do have a notary, so we can help you fill out these documents before you leave the hospital. So this is the part of the presentation where I kind of broke down some of those decisions in the living will that you might need to make. So one of the things that they might ask you is if you want something like cardiopulmonary resuscitation, also known as CPR. So this is when the medical team will manually pump your heart because for some reason it stopped beating. You've probably seen it on TV. Someone will say they're coding, and the whole medical team rushes in and someone jumps on the chest and is compressing the chest to manually pump the heart for you. The pros of this is that the whole point is that when we're compressing to get blood flow to your brain, some of the side effects of this are it can break ribs, and it might not ultimately reverse the underlying reason for your heart to stop. I felt like it was important to kind of break down some of the language that you might be seeing as you go to fill out these documents, because it can be really overwhelming, especially if you don't have a healthcare background. So I'm going to try to go through each of these things, speaking as plainly as possible, and you can absolutely ask me any questions about them further. So CPR is one of the things you might be asked about if you want or not on your living will. Another thing that you might be asked about is ventilation. So this is when you are placed on a machine that breathes for you. It requires intubation, which is when they put a breathing tube into your throat, or your breathing tube, your trachea, to artificially inflate your lungs. The benefit to this is that if you're in a really bad situation where you're not able to breathe on your own because you're so sick, the machine will breathe for you, and it gives time for your body to try to heal and recover from whatever the underlying condition is. One of the downsides to being put on a ventilator is that while we hope that we're able to get you off the ventilator, sometimes that process can be difficult for people, especially if they have underlying lung conditions like COPD, asthma, lung cancer, in which case your lungs might not be strong enough, even when they recover, to come off the machine that's breathing for you. And then in that situation, you can look into getting what's called a tracheostomy, which is a device or a little hole placed in your airway so you can be hooked up to a ventilator a long time. And that usually people will describe that as called being on life support. So you will be hooked up to a machine that breathes for you for a long period of time. Once again, when people get ventilated, we hope that that's not the case, but it is a risk that people often can sometimes get into when they need to get intubated and put on a ventilator. You also might get asked if dialysis is acceptable to you. So dialysis is when your kidneys are so sick that they're not able to work for you anymore. So you are hooked up to a machine that kind of works as an artificial kidney. It helps to remove toxins from your body. So the benefit of being on dialysis is that we have this machine that does the job of your kidneys. Our kidneys are really important to remove toxins from our body and to regulate certain levels of electrolytes. If our kidneys don't work, people don't live very long. So dialysis can help prolong your life. The negative sides to being on dialysis are that you need to go to a dialysis center multiple times a week. Sorry for the typos. And it can be for several hours. Often the session is 4 hours when you're there. Patients have found that they end up spending a majority of their time in a dialysis center. And for some people, that's not acceptable. They'd rather spend that time with their family. And also being put on dialysis because it is stressful for the body, even though it is helping, has a limited prognosis. The average life expectancy when someone starts dialysis is usually about 5 years. Now, there are people who live longer on dialysis than 5 years, but there are also people who live a shorter amount of time. So dialysis is something as well that might be in your living will, where you'll have the opportunity to say, I'm okay with going to a dialysis center 3 times a week if it's going to keep me alive. Or you can say, I don't want to be hooked up to a machine that's going to act as my kidneys. It's not okay for me to spend all that time in a dialysis center. If that was the situation, I would rather be transitioned to allowing to pass peacefully or to not be placed on dialysis. Some other questions that you might be asked to answer on your living will are, what happens if we can't feed you? As people age, our swallowing muscles start to get weaker, and it can be easier for people to aspirate, or that's when food, instead of going down our food pipe, our esophagus into our stomach, can go down the wrong pipe, our windpipe, and into our lungs. And this can be dangerous because it can cause choking, and it can also cause infections. When people end up in the situation where they aren't able to eat safely, the discussion comes to if this person would want a feeding tube or not. And there are a couple different types of feeding tubes. There are temporary feeding tubes that go either through the nose or through the mouth into the stomach, and they'll give you nutrition. So it kind of bypasses the swallowing muscles and goes right to the stomach. Those are usually temporary. We do them for a short period of time with the hope that people will be able to regain their swallowing function as they get stronger. It's not uncommon for people who have undergone something like a stroke to need a feeding tube, a temporary one, for a little while as they recover from their stroke and their speech and their swallowing muscles get stronger. There's also more permanent types of feeding tubes. So that would be a feeding tube that goes directly into your belly. It's placed usually by a surgeon or an interventional radiologist. And in that situation, the person would have a bag of liquid food that they would connect right to the tube in their stomach. And you're bypassing the mouth and the esophagus altogether. So the benefits of getting these feeding tubes are it allows you to have nutrition. People can live for long times on this form of liquid nutrition through a feeding tube in the stomach. The cons are that it is another procedure to get this type of tube placed. And the tube itself can have complications. They can become dislodged and have to be repositioned. They can also become infected. And ultimately, when people get these types of permanent feeding tubes placed, they don't really get rid of that risk of aspirating or the food reflexing up into our lungs and causing infections. For me as a palliative care provider, we're often asked to comment on patients who have difficulty swallowing if they would benefit from a permanent feeding tube. And the data has shown that with elderly adults, especially people with dementia, that a permanent feeding tube does not negate the risk of aspiration. And usually in those types of situations, we as medical providers would not recommend moving forward with a permanent feeding tube. But in other situations, it can be helpful. So it's something that you might need to think about as you're filling out your living will. Other language that you might see on your living will is if you want something called a central line with pressors. So a central line is a special IV. It's usually pretty large. It can go into the neck or the groin. And the point of this is that you want a large IV so that you can deliver very powerful medications in an area that's close to the heart. And the powerful medication that we're talking about is called pressors. So these are artificial medications that can be used to raise your blood pressure in situations where it's dangerous for them to be low. Oftentimes we see this And people who have a really, really bad infection, the infection is overpowering their body and they need a little bit of extra medication to get their blood pressure to go up, because our blood pressure is what helps perfuse our organs, our heart, our brain, our muscles, and our stomachs. So we need a certain level of blood pressure so that those organs can get the blood that they need. And that would be the benefit of undergoing, one, the central line placement, and two, to be put on those pressor medications to hopefully help the organs get the blood that they need as the body recovers from what's going on. The cons of getting these types of medications and this central line place. The central line, it does go into the neck. As you guys know, there's a lot of things in this area, one of them being the lungs. The IV is placed with a needle. You can get damage to some of the underlying blood vessels, one of them being the aorta, the carotid artery, and sometimes you can puncture a lung. That's one of the risks of, unfortunately, undergoing central line placement. The vasopressor medications I talked about, the ones that increase your blood pressure, if you're put on them at really high doses or for really long times, it can cause clotting and it can cause some issues with circulation, specifically in the fingers and toes. So another thing to kind of think about if that's acceptable to you when you're filling out this paperwork. So that kind of includes everything that you might see when you're filling out your living will. I wanted to give you guys at least a taste of some of the questions so that you could anticipate how you would respond as you're working through the paperwork. The other type of advanced care planning, advanced directive. So the second document that we talked about is making a durable power of attorney for healthcare. And once again, this is that person that you would appoint to make medical decisions for you. If God forbid you were ever temporarily or permanently unable to make decisions for yourself. And you might be thinking about who would be this right person for me. So it should be a trusted adult, someone who's older than 18. And it's someone who should know you well, who you feel confident would know your wishes, your beliefs, your values, and the things that are really important to you. There are a couple of rules about who can't be your medical power of attorney. That would be the doctor taking care of you, unless for some reason that doctor happens to be related to you and is a member of your family. There's some issues maybe with bias here. So that's why they don't recommend that at all. And I legally don't think it's an option. And then secondly, the owner, operator, or employee of the healthcare facility that's currently taking care of you cannot be your medical power of attorney. Once again, I think it has to do with something legally, maybe some bias involved, unless that person is related to you, unless you are hospitalized at a hospital where your CEO is like your very close friend or your family member who you've appointed to make medical decisions for you already. The durable power of attorney ends when you're able to communicate. So in situations where, say, you would get really, really sick, you're way too tired to communicate your wishes, this document becomes active. Your trusted person becomes your spokesperson to the medical team. But once you recover and you're able to participate in those types of discussions, the power goes back to you and your healthcare power of attorney has done their job, but now you're better and you can make decisions for yourself. And it can be more than one person. If you're someone who has lots of trusted people in your life or people who you feel would do better making decisions together, you can document that you want more than one person to be your healthcare power of attorney, and how much power and what kind of decisions can be allotted to each person, whether they'll have equal decision making, or if one person will have more say than another. That can get a little bit complicated. And if you are planning on doing more than one person as your healthcare power of attorney, I would make sure that both of those people, or as many of those people, know that they are sharing responsibility.
All right, Dana, we got some questions coming in now.
Awesome. Perfect. This is a good place to do some questions.
Awesome. So starting with Ken, great question. With the medical power of attorney for someone with dementia, and we're talking about being able to communicate, how do you kind of navigate that? And so I think Ken's question is specifically to what is meant being able to communicate for a patient with dementia. And I would expand on that a little bit to say, you know, what are some of the other considerations that you're making with durable powers of attorney for someone with a dementia diagnosis?
Definitely. So as you know, people with dementia, their ability to communicate is really limited. And sometimes their cognitive ability to make those higher level decisions is difficult as well. Dementia is very varying. Some people are able to have those types of discussions and some people aren't. Legally, the next power of attorney by law, if they don't have this kind of paperwork set up already, is going to be either a spouse or an adult child. If luckily you were able to kind of do this paperwork beforehand and it's someone else, then they would go with the durable power of attorney paperwork. And I think what can be helpful for patients with the dementia is to kind of sit down with this person, hopefully their medical provider as well, and maybe ask them if they have the ability to make this decision for themselves or not. Because unfortunately, with advanced dementia, they might not be able to communicate who they would want to be their person. If that's the case, it does kind of default to the legal system, to those family members in place. And there are some challenges for family of choice, which I'll talk about kind of at the end. But some people with dementia are able to participate in those kinds of discussions and are able to say, I'm okay with you making those decisions for me, or I want you to be the person to make those decisions for me. So it kind of depends on the ability of your loved one to be able to communicate those kinds of decisions. And if you feel like that they're not able to kind of make those decisions, bringing in either your primary care provider, your geriatrician, or your palliative care specialist, if you have one, to kind of help navigate that is what I think the next course of action should be. I hope that helps, Ken.
Great, thanks. And then another one was on, and you'll likely get into this, but like how time bound are things? So for example, if someone says, yes, I want dialysis, and then after a couple of months of doing that decides, no, they don't. Or are you able to specify sort of, I'm willing to do dialysis for X number of months, and then if it's not having positive signs to then stop? You know, how much of that do you go into upfront?
Totally. It all kind of depends on your own thoughts about it. What you're describing is called a time limited trial. So that's when we say, hey, I'm okay with doing dialysis for a month. I'll do a couple sessions. If I can tolerate it and I'm okay with it, great. Then I'll continue with dialysis. If after a month, after a couple sessions, it's clear that it's not really working for me, then the decision would change. Usually in the case of dialysis, if people are unable to tolerate it due to low blood pressure, due to making them feel really, really crummy, or if they're finding that it's just too overwhelming for them, you are looking at an end of life situation. And the next best move, if you're not moving forward with dialysis, even though you need it, is something called hospice. In regards to time limited trials for other things, it can be variable and it can be as long or as short as you want. Sometimes we do this with the temporary feeding tubes. I think the example I gave you guys was a stroke patient. So a patient comes in, they've had a stroke, they're really weak swallowing muscles. They get a tube placed down their nose that goes into their belly that allows them to eat as they're recovering. You can say in your advance directive, if you're that patient, I'm okay with doing a tube down my nose for a limited time, a couple of days, a week, to see if I get stronger and recover from my stroke. But then ultimately, if you make the decision that you're okay with a more permanent tube placement, they would move forward with that, because you can't really leave the hospital with a tube that goes from your nose to your belly. They need something more permanent and more secure placed. Or the alternative would be something like, you know what, after a set amount of time that's dictated either by you or with the help of your medical providers, because you can always ask us, what's an appropriate amount of time for someone to be on dialysis before they see if it's working, to need a feeding tube before we know if they're strong enough to recover their swallowing function. If after that amount of time, you decide, you know what, I don't think I'd want to be a tube that goes in my stomach to get artificial nutrition, then you don't do it. And you kind of recognize the risk that aspiration pneumonias might be there, and you accept that risk. And then you work with a speech therapist to try to minimize that risk by having as safe as a diet as possible. So with time-limited trials, you absolutely can put that in your advance directive. And it can help your family too, if you're unable to speak for yourself or whoever's making the decisions for you, to know, okay, Dana was okay with doing a month or two of dialysis. And if it helps, great. If it doesn't, she's indicated that she'd like to move to hospice. And if you need help trying to determine what's the appropriate time frame that people should try these therapies or are willing to try these therapies, that's absolutely when you can come and talk to me as a palliative care provider, or talk to your primary doctor. And your primary doctor can help you with this paperwork as well.
You may, Dana, have just kind of answered the follow-up question that came in the chat. But so do you actually write time limited on the document?
If you write time limited, the medical provider will know exactly what you mean, but you don't have to. You can say, like, I'm willing to do dialysis for 1 month, or say, I'm willing to be on a ventilator for X amount of time. The ventilator time, I can tell you, there is more of a set number. There have been studies that show that when people spend usually more than 14 days, specifically up to like 3 weeks, so 21 days on a ventilator, that tube in the throat causes so much irritation to the airway that it can narrow. And even if you're able to get that tube out, the irritation causes fibrosis. Again, it can cause a whole bunch of issues. So when people end up on a ventilator with a tube down their throat for up to usually about 2 weeks, they'll start talking to you about what I mentioned earlier, which is the tracheostomy. So if you are someone who's a planner and you want to put time-limited trials in your advance directive, specifically the one with the ventilator, it might be helpful, because if you know that you don't want a hole in your airway to be hooked up to a machine that breathes for you, the tracheostomy, then it might be beneficial to say, I'm okay with being ventilated for up to 2 to 3 weeks, but I'm not okay with having a tracheostomy placed and being on a vent for longer than that. So I hope that was helpful.
Great, thank you. And thank you, folks, for the questions. Feel free to keep getting questions in. But Dana, you can keep going with the next slides.
Awesome. So these are just some examples of what this paperwork might look like for you. So I pulled this one from UPMC. They all look different and it can be a little overwhelming, but ultimately the kind of questions that they ask you will be the same. So this one, very basic, looks like they just kind of want your background information. If you have someone who's helping you fill out this paperwork, you put their information there. And then you kind of check off what you want. And this one breaks it down really specifically. So this one says, like, your medical decision maker can have total flexibility, some flexibility, and then actually page 2 of this, which I did not include, but you can find it online, is where it goes into the medical therapies that you'd want. And then let's take a look. Another one is called the 5 wishes. So we actually have this in our office. This was designed by, I think it was a palliative care team to really kind of gently walk patients and their families through the kind of big decisions that they might need to make as they get older, as they approach end of life, and as their medical conditions get more severe. If you're interested in this one, definitely talk to your primary care doctor. They might have it in their office. Come to my office, we'll give it to you. And you can find it online at the 5 wishes. So people tend to really like this one a lot. Okay. This one was through Penn State. And then this one is the medical power of attorney. So kind of at the top, you list like your name, your county. This looks like it has some legal mumbo jumbo that says ultimately that your healthcare agent is the person that will make decisions moving forward for you. And then you put down who you would want that person to be and their information here. And anytime you come to the doctors or to the hospital, if you're able to bring these paperwork with you, or if your loved one is able to make sure that they get to your primary care doctor or come with you to the hospital, those are things that we can scan right into our computer system and that will have them. So it's always good to bring extra copies with you. Okay, let's see if I have another one. You might have heard of something called a POST. So this actually isn't an advanced directive, but it's similar. So that's kind of why I wanted to include it in this conversation. So a POST stands for Physician Order of Life-Sustaining Treatment. It's a form that you can find online if you Google it. But it ultimately outlines your wishes for healthcare in the event that if EMS showed up and you were having a cardiac arrest and you're someone who did not want to be brought back undergoing intubation or CPR, this form would allow you to pass naturally at home. So it's non-advanced directive. It doesn't really break down some of those other discussions that you and I were talking about, but it does state if you would want CPR, if you'd want to be put on a ventilator, because those are things that our EMTs need to do quickly if you want them. And it's okay if you don't. It also outlines if you want to go to the hospital or if you would rather stay at home. It has to be signed by your doctor. So either your primary care doctor, or if you're hospitalized and you want your physician to sign this before you leave, that's something that we can do in the hospital for you too. And so just a note, where this is different is that the EMTs and paramedics who show up when 911 is called cannot use an advanced directive. I don't really know why, but I just know that that's the case. And this is kind of where a POST form comes in. So if you're someone who's had the discussion with your family, with your healthcare providers, that you would, in an emergent situation, prefer to allow a natural death and to be made comfortable, to not undergo CPR, to not be put on a machine that breathes for you, filling out a POST form is important. Because when EMS arrives in this kind of situations, their priority is to do what they were trained to do, which is to prolong life. So they will start CPR and they'll put you on a machine to breathe for you. And this form can be really helpful to prevent that from happening if it's something that you don't want. Let's see. And this is what it looks like. So, your name, your date of birth. The top part is the CPR that we talked about. That's the chest compressions. That's if you would check if you want that or if you don't. And then if you don't, you talk about the kinds of things that you would want. So comfort measures, those would be things like putting you on oxygen to keep you comfortable, giving medications to keep you comfortable, or if you'd want full treatment. So you'd want to be intubated, you'd want chest compressions, you'd want electric shocks if you need it. So this kind of helps our emergency providers with some decision making as we get you to the hospital.
Dana, is that the same as a do not resuscitate order?
Yes. So a lot of the language is the same. A
Okay.
do not resuscitate order is an order by a doctor when someone comes into the hospital about what they would want done if the worst case scenario occurred. And that would be if for some reason while they were under our care, their heart stopped or they weren't able to breathe on their own. There are usually two options. The first is full resuscitation. So that's the CPR. That's the being put on a ventilator, and that's electric shocks if you need them. The other option that we give to our patients is called a DNR, which is do not resuscitate, do not intubate, and I call it allow natural death. So if you were in the hospital and your heart stopped for some reason, you weren't able to breathe on your own for some reason, if you were a DNR, it doesn't mean that we wouldn't do anything. It just means that our focus would change. We would recognize that you would not want extreme interventions to prolong your life, that you're going through a natural stage of dying in this moment in time. And what the healthcare providers would do is they would contact your family to have them come in and to be with you and to ultimately do the things that we can do to make you comfortable without speeding up the natural dying process. So that's when we would give you medications to make you comfortable, whether that's things like morphine or Ativan, and to kind of help you have a peaceful transition. I hope that answers your question.
Yes, thank you. Other question that just came in. So in cases where a patient cannot make decisions for themselves, and there might be some difference of, let me actually make sure I get the exact wording right, on life support issues. And there's difference of opinion between family and doctors. So times when there is dispute, how does that get navigated?
It can be super, super challenging. And I've definitely run into this during my time as a palliative care doctor in the hospital. Sometimes people will end up on a ventilator, and then decision-making does default to their healthcare power of attorney. In some people's cases, it can fall to their children. And if there's more than one child, then they have equal decision-making responsibilities. And I've walked into situations where, two of the kids say they don't want to continue life support or the artificial ventilation, and two of them do. It can be really, really tricky. And ultimately, you need everybody to be on the same page because they have equal power to make a decision. And that's oftentimes when your medical team will pull in someone like me who is palliative care trained to talk about the options with your family members to make sure that they're getting all the information, even if it's the information that they might not necessarily want to hear. Because the goal is that ultimately everybody needs to be on the same page moving forward.
Great, thanks.
Of course. All right, so that was the post. So I think we might have answered this question earlier, but I did include some frequently asked questions that I thought were pretty good ones about advanced care planning. So is a living will the same as a DNR? So we chatted about this a little bit. No. So a living will covers all different types of life-sustaining treatments, not only CPR and ventilation, but things like dialysis, things like feeding tubes. A DNR only covers life-threatening situations like when your heart stops or when you're not able to breathe on your own, in which cases your medical team knows not to do chest compressions or not to put you on a machine to breathe for you, the ventilator. Okay. Does a living will affect insurance? No, just because we're having these conversations, it really shouldn't affect your ability to get any kind of insurance, whether it's health insurance or life insurance. And I legally don't think that it can. So it should not affect insurance at all. It can only help you and your family be prepared for worst case scenarios. And then this question. So what happens if, God forbid, you got so sick, you weren't able to do this paperwork? Who would be your medical power of attorney? So in the state of Pennsylvania, the next of kin takes over responsibility for your medical decisions. That would be if you are legally married and have a spouse. Second would be adult children. Third would be parents, if they still happen to be around. Then it would be adult brothers and sisters, and then it would be adult grandchildren. If in the event that you're in a second marriage, your current spouse and your adult children from the previous marriage would have equal decision-making responsibilities. So as you guys can see, if there's multiple people involved, or if there's been previous marriages, or if you're legally married but separated, you can kind of run into some murkiness here. But if you fill out a durable medical power of attorney paperwork by doing an advance directive, it'll be very clear who you want to be your person. And it doesn't need to be any of these. It could be a very trusted friend. It could be your cousin who you've known forever and knows you extremely well. But if you don't have that paperwork, this is legally the chain of people who would be making decisions for you.
And I would just highlight with that. So again, for unmarried, so someone who might be partnered but not legally married, that yes, unless you have the paperwork, the partner is not going to be recognized. Is that right?
Yes. And that's one of the challenges. And I'm going to get into this in the next couple of slides, but if long-term partners, people who, are your person, but you're not legally married to, no matter how long you've been together, if it's not on paper that you want them to be your decision maker, they would lose that right and that power. And I've seen that happen a couple of times in the hospital. And it's really, really heartbreaking for that person who knows you the best and has been with you forever to legally not be able to make decisions for you. And it might default to someone who you might not have as good of a relationship with, or someone who you didn't want to make those decisions for you. So why is all this important? We definitely chatted about a couple of these things. So
and I just want to real quick, Dana, just give about a 10-minute time check. So I'll hold questions until you can get to the rest of your slides.
Okay. There's only 2 more. So hopefully we'll be able to get through it on time. But for our LGBT older adults, we know that they're twice as likely to age alone. They're even 4 times more likely or less likely to have children. And that often this population has delayed entering residential care settings, so places like nursing homes, due to stigma and how they will get viewed. There's a bigger reliance on families of choice and friends to kind of help with decision-making process in our LGBT patients. And oftentimes in this population, when they're seeking out medical care, there's the issues of marginalization, stigma, economic issues. It can be really challenging, I imagine, for our patients who are trans to go forward with this legal paperwork, as they might struggle with things like dead naming or struggle with pronouns and what needs to be put down on a legal document. And oftentimes our LGBT plus patients have expressed the feeling of being forced back into the closet as they age and as their disease progresses. So these are some challenges with having these types of conversations. So we also kind of touched on this, but state surrogacy and next of kin is often based on biological families and really excludes unmarried partners or families of choice. So we spent a lot of time talking about this just a couple minutes ago, where it's really important, if you don't want your biological family to be making choices for you, to get down on paper who you want that person to be. They did a study where they looked at LGBT patients and how often they were talking about end-of-life issues with their primary care providers as opposed to the other people who don't identify as LGBT. And they found that LGBT patients actually talked with their doctors about end of life, made a living will, and appointed a healthcare proxy more than the general population. So kudos there. But what they did find is that our LGBT patients were not discussing this with their significant others. And it's not really clear why, but knowing this information, I would take it back and make sure that you are having those types of discussions with who's important to you. And even though the LGBT patients were better, the general population, with talking about these types of things with their primary care doctor. They looked at the numbers. It was only about 1 in 10 LGBT patients were actually having these types of discussions with their primary care providers. And then this study also found that transgendered people have the lowest prevalence of legal documentation at the end of life. So only 14 of them have completed a will, only 13 of them have done a living will, and even less, only 11% assigned a healthcare proxy. So just some foods for thought as you guys are on your advanced care planning journey and starting to think about these things. And I wanted to thank you all for having me. It's been a pleasure to share my knowledge with you. And this is my dog, Huckleberry. He's a Black Lab rescue. And I'm more than happy to answer any other questions you guys have.
Thank you for the dog picture. Nice to end on a more uplifting note.
Yes.
Thank you so much for the presentation and taking all the questions. I think we probably have time for a couple of additional questions if folks have them. So the one that did come in from Rob is just, is it always so complex? And Rob, I hope that is hope this made you think about sort of all the different things that go into it and not feeling overwhelmed by it. But Roger said that this changes many of my preconceptions about palliative choices. So wonder if you have any reaction to that, Dana.
Absolutely. Rob, I hope I didn't overwhelm you. I know this was a lot of information to take in, and it can really, really be scary and overwhelming to think about these things. I will say that most of the time, it is not this complicated. I will say that while I do see patients in the hospital, I have to constantly remind myself that the majority of people don't live at Thomas Jefferson University Hospital, that people live out in the communities. And a lot of the times people don't need to use their advance directive. But it's important to kind of think about these things and the types of questions that you or your loved ones might be asked in the worst case scenario situation. Because every once in a while, bad things do happen and it can get that complicated. But I'll reiterate that the majority of the time, you shouldn't have to be in that situation. This is really hoping for the best, but preparing for the worst. And once you do this paperwork, once it's out of your hair, you can put it aside and forget about it, but have the comfort of knowing that it's there for you and it's there for your family and your people if you end up in a worst case scenario like that. And if you're feeling overwhelmed, you can absolutely talk about it with your primary care doctor or an outpatient palliative care doctor to discuss these things further, and they can break it down for you as much as you want and to help you through it. So hopefully it's less overwhelming.
And that kind of is another thing I just hope you could touch on briefly. So just the pure logistics of filling out these forms. Do people make appointments with you to come in and say, I'm starting from scratch, I want to sit down with someone and do an advance directive? Do you make appointments with that? Do folks go to their primary care doctor? What's the best way for folks to get started who maybe aren't comfortable just kind of taking these forms off the internet and getting going?
Yeah, it can be really intimidating to just download a form off the internet and start filling it out yourself. I know on our team, we do have a social worker who does help people fill out this paperwork all the time. And there hopefully should be a social worker connected to your primary care doctor's office that can definitely help you move forward with this kind of paperwork and answer any questions you might have about the logistics of it.
Thank you. Any last questions that folks want to get in before we break? And that's okay if not, because I know Dr. Hovering, you covered many of the frequently asked questions before earlier on the slides. And for someone did ask, I will share out the recording. Give me a couple days just to get it posted. But as long as you registered or and I have it, as long as you got the reminder email from me, I do have your emails and I will send out the recording. Dr. Hovern, thank you so much for this great presentation. Thank you for being part of our Doctors In programming. I hope we'll see you again this year. And thank you everyone who joined us today, either on Zoom or on Facebook, or who are watching this recording later. I hope this information is helpful to you, because it's a lot to think about, but obviously very important things. And Dr. Hovern, I will leave you with the last word to close us out.
Thank you guys so much for having me. It's been a pleasure to share my knowledge with you. And I hope you found this helpful, but not too overwhelming. Stay well.